Mastoid obliteration is a surgical procedure performed to fill the mastoid cavity with various materials, aiming to eliminate the cavity and prevent recurrent infection or complication associated with chronic ear disease. Objectives of mastoid obliteration: first is prevent recurrence of infection or cholesteatoma. Second, it reduces the size of mastoid cavity to simplify postoperative care. Third one is it improves patient comfort by eliminating cavity related problems such as chronic drainage and need for frequent cleaning. Fourth is enhance the effectiveness of hearing reconstruction procedures. Indication for mastoid obliteration. First indication is chronic otitis media, particularly with persistent drainage infection despite prior surgical intervention. Second is cholesteatoma, when complete eradication is challenging and there is need to reduce the risk of recurrence and residual disease. Third one is recurrent mastoiditis, in cases where conservative management and standard mastoidectomy have failed to prevent recurrent infections. Fourth is failed mastoidectomy, when a patient continues to have large problematic cavity after a previous mastoid surgery. Fifth is recurrent or persistent discharge, to address constant otorrhea that fails to respond to medical management. Sixth is radiation induced otitis media, in patients who have had radiation that affected the medullary mastoid, causing non healing cavity. Seventh is cosmetic and functional reasons, to create a smaller, more manageable cavity that is easier for the patient to maintain and improve cosmetic outcomes. Contraindication for mastoid obliteration: active infection, inadequate surgical clearance of disease, poor eustachian tube function, limited access or visualization, and some patient specific factors like general health, inability to tolerate surgery, hemorrhagic disorder, anatomical variation that might increase the surgical risks. Techniques of mastoid obliteration. First is autologous material like bone graft generated from patient own mastoid cortex or cortical bone. Fat graft harvested from abdomen or other area like thigh. Cartilage and perichondrium commonly used from the conchal wall or tracheal cartilage. Second is alloplastic materials like hydroxyapatite. That hydroxyapatite is bioactive ceramic material that is osteoconductive. Bioglass, titanium or silicone, silica based glass that integrate with bones, that is bioglass. So these are alloplastic materials. Third one is vascularized flap. Temporalis muscle flap, a robust flap that brings vascular tissue into the cavity. And periosteal flap to provide coverage and reduce the risk of cavity problems. Surgical technique overview. After doing canal wall mastoidectomy, you have to choose obliteration material to obliterate the cavity, and you should carefully close this cavity and proper closure of the canal and mastoid skin incision. Postoperative care monitoring, regular follow-up to monitor for complications such as infection, material extrusion or cavity recurrence. Ear care, instruction to keep ear dry and managing any drainage or discharge. Audiological evaluation, assess hearing improvement or any residual hearing loss. Complications: infection, early or late infection of obliterated cavity may be there. Material extrusion, displacement or extrusion of obliterated material. Recurrent cholesteatoma, if not all disease is removed, recurrence can occur. Hearing loss, residual or worsening hearing due to surgical trauma or ossicular chain reconstruction failure. And facial nerve injury, a rare but serious risk in revision surgeries. Outcomes and benefit. First benefit is reduction in infection rate by eliminating the cavity that harbors infection. Second is improved quality of life. Third one is hearing preservation by combined with this technique with ossiculoplasty. In conclusion, mastoid obliteration is an effective procedure for managing problematic mastoid cavities when performed with proper indications and patient selection. Understanding the nuances of surgical techniques and careful planning is essential to achieving optimal outcomes and minimizing complications. The ultimate goal is to improve patients' quality of life by providing dry, safe, manageable ear environment.